Hello, good evening, everyone. Welcome to another edition of the ASMBS Bariatric Happy Hour, where we're all happy for 1 hour. Yay! I'm super excited to introduce our guest speaker tonight. Actually, I forgot. Do we have any announcements? So stay tuned for the beginning of the month, the first Friday. We have our Fellows Project, and the speakers this month will be Dr. Jain-Spangler. Can you tell us?
Yeah, so we're going to have two fantastic speakers teaching us how not to mess up a sleeve gastrectomy. So Dr. Thompson up in New York and Dr. Kukreja from good old Texas. They will be teaching us about sleeve gastrectomy and, more importantly, how not to mess up a sleeve.
Great. Tonight, though, we will be having a special edition with Dr. Ayoola. Dr. Ayoola is a well-renowned DS specialist, and he'll be talking to us tonight about DS for Dummies, how even a left-handed surgeon, in his words, can perform this procedure. Dr. Ayoola comes to us from Dallas. He completed his medical school at UT Southwestern in Dallas, and then went on to do residency and fellowship at Virginia Commonwealth. This is in Richmond, Virginia. He's now the medical director of bariatric surgery at Presbyterian Flower Mound, and he has performed probably innumerable operations. He does over 100 DS procedures each year, including revisions. We are very excited to have him talk to us and simplify the procedure. I'm also joined tonight by Dr. Jain-Spangler, Dr. Dan, and we are awaiting arrival of Dr. Chaar, who's in our waiting room and should be coming on soon. All right, without further ado, Dr. Ayoola, take us away.
Thank you so much. Can you hear me okay?
Great.
All right, I'm going to share my screen. And I just want to say that I hope no one takes offense to the title of the talk. It's not that I consider anyone a dummy. It's just that the book series is really good for learning. And that's what we're going to try and do some learning. So the agenda I have out is a brief history. Don't worry, I won't spend too much time on this. A brief history of duodenal switch, kind of a loose selection criteria, the anatomy you should be aware of to do this safely. And then I'll go into technique, and I'll talk about laparoscopic technique as well as robotic technique. But I'll be honest, I'm going to focus mostly on robotic technique because I think that's kind of where things are headed. And that's what I currently do mostly is robotic duodenal switch. Briefly on data, I'll talk about billing. Anyone in private practice, billing is going to be important for the duodenal switch. And then I'll talk a little bit about how to follow up on these patients and how to take care of them because, you know, surgery is only part of the battle. It's very important to be able to take care of these patients long term. So from a historical note, the DS is an operation derived of the biliopancreatic diversion by Dr. Scopinero and the Demister duodenal switch by Dr. Demister. Now, the BPD was to address bypass issues, in particular, inadequate weight loss. And the way it accomplished that was to make sure that your common channel was very short, anywhere from 50 to 100 centimeters. And to support the fact that you have so little intestine to absorb food with, you compensated for that by making the gastric pouch much bigger than you would with a gastric bypass. The Demister DS, on the other hand, did not really focus on intestinal lengths and was purely to divert bile away from the duodenum, or at least the proximal duodenum, so you could not have bile reflux. So it's a bile reflux operation. Marceau and Hess put these two together using the shorter limb lengths of the BPD in conjunction with the biliopancreatic diversion with the Demister DS. And then they added the sleeve gastrectomy component to kind of finish off the weight loss aspect of the operation. So that's how the operation was kind of developed. This is one of my patients that had a duodenal switch. I love this picture because she has a testimonial online as well of how she felt here with a BMI over 50 and how she feels now with a BMI at about 28, 29. My selection criteria loosely is a BMI over 50. There's literature suggesting that if you have a patient with a BMI over 50, they don't lose or maintain weight loss as well with a sleeve or a bypass. So in general, if a patient has a BMI over 50, to reduce their chance of weight recurrence, weight regain, a duodenal switch is a better operation. If you pick the sleeve or bypass for these patients and they do regain weight, it's not too late. You can convert their sleeve or bypass still to a duodenal switch. As we all know, if you convert a sleeve patient to a bypass, you may help them with reflux, but I don't think you help them as well with weight loss. And so both sleeve and bypass patients get converted to a duodenal switch. So the other time I would like some tea, by the way. The other time I would consider DS strongly is in diabetics. Not the ones on metformin or glyburide, but folks on insulin, especially high doses. One of the kind of touchy-feely things is that's very hard to kind of gauge, to be honest, is to make sure that the patient has an ability to understand and commit to the protein requirements and the vitamin requirements, as well as the follow-up requirements after a duodenal switch. This is very difficult to quantify. This is very difficult to kind of tease out. I've had patients come in with notebooks, looking very serious, glasses on, writing down everything I say pre-op, and then ghost me post-op because they think they got it figured out, and then have issues and come back and you have to help them solve those. So it's very difficult to know that. But if you do have someone that comes in and you say duodenal switch and you draw it for them and you talk about it and they're like, I don't understand how much protein, what's protein, that's probably not someone you want to give a DS. You just want to make sure the patient has a reasonable understanding. Patients oftentimes come in and they will tell you, I don't eat a lot. Okay. But some patients come in and they tell you point blank, I love food. I eat a lot. I enjoy food. This is an ideal DS patient. This is someone that's well aware that they want volume and they want frequency and things like that, and they enjoy food. The DS is an operation that counterintuitively patients have a larger sleeve gastrectomy so they can consume more food, but conversely lose more weight than the other operations. So my foodies, I think it's a good option for them. And for folks that want a one and done kind of mentality, where they do one operation kind of to rule them all, the DS would be that. So moving on to anatomy, obviously the critical thing, and we all know this part is easy, is knowing where duodenum is. You know, you follow stomach distally, you run into duodenum, you can't miss it. Some of the things you should know about the gastroduodenal artery, we talk about that a lot. It's posterior to the duodenum, kind of at the head of the pancreas. Most DS surgeons use this kind of as your distal marker. If you're dissecting out the duodenum, if you see the GDA, you've probably gone far enough. You don't need to go any further. I think it's even more important to understand where it is so that you don't dig into it, because if you dig into it and it starts to bleed, that's a miserable area to try and control hemorrhage. So that's why I think it's important to know where the GDA is so you never get to meet it, at least not in that way. The other vessel that kind of gets a lot of attention with the duodenal dissection is the right gastric artery coming off the common hepatic. Most patients, this artery is very small. You could easily miss it. You could easily take it without even knowing. The important thing here is that you have a vascular arcade where the left and right gastric meet each other. And so you could take the right gastric and it's going to backfill from the left gastric, in particular, if that hasn't been taken by a previous gastric bypass. And then, of course, you have the short gastrics. We're all familiar with those. We take them during a sleeve gastrectomy. Now, here's what people fear the most, appropriately so, the portal triad. The portal triad is sitting in the hepatoduodenal ligament, common bile duct, portal vein, proper hepatic artery. And you notice all this isn't superior to the duodenum, at least where you're going to encounter it. This is the reason why when you watch video of people dissecting superior to the duodenum, they're very ginger with it. They don't want to go too deep. They want to hug the duodenum very closely. And that's actually why I don't like doing the superior dissection, because that's actually where things are most dangerous, in my opinion. Unfortunately, when you hug duodenum, even though you're avoiding the portal triad, you're devascularizing it. And you see oftentimes people talking about blue duodenum. That's because you devascularize it superiorly, inferiorly, and you end up taking all its blood supply. Now, it still survives and it's not the end of the world. But if you're trying to avoid that blue duodenum, I'm going to show my technique that avoids this superior dissection and also respects the hepatoduodenal ligament and avoids getting you in trouble there. So these are the steps to a traditional duodenal switch. These don't have to be followed in exactly this order. Ultimately, you're going to divide duodenum, of course. You're going to divide the ileum at your total alimentary limb length, i.e., from the ileocecal valve to where you're going to make your duodenal ileoanastomosis. You're going to divide the ileum there. You're going to create a duodenal ileoanastomosis, and then you're going to finish that off with an ileoanastomosis that's now going to have the total alimentary limb divided to the common channel, as well as the alimentary limb. And of course, you're going to do a sleeve gastrectomy. So this is an animation showing that, dividing the duodenum, dividing ileum, making your anastomosis proximally and distally, and then a sleeve gastrectomy. This allows food to go down the alimentary limb, denoted in blue, and pancreatic juices to go down the biliopancreatic limb, denoted in green, and then the common channel, denoted in red here, is where all the action happens. In general, I'm going to make my common channel 100 centimeters for a patient that's female with a BMI over 50 or a male with a BMI over 60, since men tend to lose more weight, even though they don't want to lose too much weight, whereas most female patients don't mind as much weight as they lose. They kind of want to maximize their weight loss. If the patient's BMI is less than 50, I'm going to make the common channel anywhere from 125 to 130. The most I'll make a common channel is 150. I think once you go higher than that, you really start to affect weight loss. And you don't really need to, at least not on a primary operation. If it's a male patient, BMI less than 60, same thing applies. But that's the what you're trying to do surgically. It's really nice to be able to visualize it, to be able to do this intraoperatively. So with the SADI, you're just dividing duodenum and then bringing a loop of bowel up. Most people will have what you would typically consider the common channel at 300 centimeters. Early experience, people were doing this at 250. The degree of malnutrition was higher. Part of that is because we count bowel really badly. So your 250 sometimes is actually 230, 210, 200. And so 300 kind of gives you that 250 to 300 range, even if you miscount. So same thing here, divide duodenum, make a duodenal ileoanastomosis, and then finish that off with a sleeve gastrectomy. So here's my laparoscopic technique on the duodenal switch. This is a traditional DS. Find ileocecal valve, and I'm using Ethicon Babcocks here that are 5 centimeters on the silver aspect. And so I'm going to use that to count. Once I count out the common channel, I'm going to mark it with a stay stitch, and then I'm going to march out the alimentary limb. And once that's done, I'm going to divide the alimentary limb off the BP limb on the left of the screen, alimentary on the right, divide the mesentery as well. And then I actually run the alimentary limb back to my stay stitch. This allows me to keep orientation. And then I'm going to bring the BP limb up to the alimentary limb, the stay stitch, fire a stapler after enterotomies, and then go on and close this common enterotomy, whichever way you prefer. I do a running Lambert with a braided suture, even laparoscopically. And then I close the mesenteric defect. Obviously, there are people that don't close mesenteric defect. The rationale is that if you don't close it well, you have more serious bowel obstruction if something happens. But if you don't close it at all, you have a higher rate of internal hernia. So you kind of have to pick your poison there. So what I'm doing here now is just tacking up the roux limb, because I'm going to put the patient in reverse Trendelenburg, and I want to be able to easily find that later. And this is the most straightforward part, obviously, doing a sleeve gastrectomy, taking the short gastrics. Now here you're seeing the antrum, you're seeing the pylorus, and now we're using the vessel sealer to take down the inferior vessels. So this is the inferior dissection. I do something very similar robotically, and I'll show you that, but it's the same technique. So the idea here is to hug the duodenum. You could take this in layers if you need to. If you could get around this in one bite, that's fine. If you can't, just take what you can see. I like the technique because you're seeing everything very clearly. So now I'm going to raise the duodenum to the 12 o'clock spot and really focus my attention on the posterior dissection. I'll tell you that I don't do all this anymore. I find that you actually don't even need to take these down. Usually your stapler will take care of that. But you notice there that I only took that to the superior. I'm going to go back. I take this just to the border, the superior border of the duodenum. I don't dig any higher than that. That's all I need. I just want to make sure duodenum is free. So sleeve gastrectomy is done. I kind of skip through that. And now I pass the stapler posteriorly and don't do any superior dissection and clamp down. If you need more duodenum, you can rotate and pull the duodenum to the patient's left to get a little bit more. And once you fire it, this is the view you'll get. This is hepatico-duodenal ligament here. And you see that when I lift this up, you can really see the angle here where hepatoduodenal sits, right? So when you pass the stapler in this direction, it's very difficult to get around it. Now, if you were coming, say, from the patient's left, going towards the gallbladder, you could get around it. But when you're coming from the patient's right, it's virtually impossible to staple around it. Obviously, don't try to, but coming from that angle, it's difficult to do that. Laparoscopically, I put a clip. That's where the right gastric is, up here. I don't want to suture here. I don't want to do anything too aggressive here. I do want to get hemostasis, but I don't want to be super aggressive while trying to do so. So the rest of this is pretty straightforward. Once you've divided duodenum, we're going to bring the alimentary limb up. What I end up doing is running a posterior row. I think one of the important things when you run this posterior row is that on the small bowel side, you want to be very close to the mesenteric border to leave enough tissue for you to be able to sew to when you're doing your second layer. I will do a 1.5 layer. So I do a posterior row to kind of hold everything in place. And then I'll do an anterior row on the back end, but on the front end here, I'm going to do kind of a running Lambert, imbricating the serosa. And I'm only going to do that in 1 layer. Of course, you could run this in 2 layers. That's not a big deal, but this works well. I will test the anastomosis with methylene blue to make sure it's not leaking. That's what we're doing here to make sure that that anterior repair is sturdy and holds up well. The last thing here is just closing Peterson's defect. Again, some people don't close this. You have a higher rate of internal hernia if you don't close it, but it's important also to close it well. If you don't close it well, you will have, even though a lower rate of internal hernia, it will be a more serious complication if you do encounter it. And so it's important, if you're going to close it really well and have good technique on how you close it. I will end up taking the specimens out and then using the V-lock to close the hernia defect after the specimen has been retrieved. A few patients have had to go back and take out their gallbladder afterwards, and I find that this repair really holds up well and works well. You don't necessarily have to use the Carter Thompson, even though it's an option. So now I'm going to move on
Dr.
to.
Ayoola, I'm going to interrupt you just
Please go
for
ahead.
a second. So that's awesome so far. I do want to stress to everyone on that you don't have to hold questions until the very end. It's supposed to be informal. So if you guys have anything that you want to ask as we're going through the presentation, please feel free to interrupt the speaker. We have the option of reading your question, or we can promote you to the panel. Oh, great. Now I've said that, I actually forgot my question.
I have one if you
Okay, yeah, please go ahead.
take a second to remember. So Folahan, I recently just sometimes you want to try out something new. So I recently started doing a periduodenal dissection.
Mhm.
How do you feel about that?
When you say periduodenal, are you dividing everything inferior and superior? Are you?
Yeah, so I make a tunnel, essentially. I pick the spot where I want to come across the
Mhm.
duodenum. I'll dissect the periduodenal fat right there. I'll tunnel directly under the duodenum and actually pass a band passer around the duodenum there so that I know I have a safe tunnel. I'm not going to injure anything hepatoduodenal. My stapler is going to pass easily. And then I have some of that attachment still left at the distal stomach that
So, yeah,
might help some with flow.
I like what you said, because you said, hey, I'm trying new things, right? Because you've gotten to a point where it's more, the operation has gotten a little more boring for you. So now you're experimenting with, hey, what can I get away with? And I think that's
somebody in our, Peter Nong is a fantastic surgeon. And, I take my fellows to watch other people do surgeries. And so we watched, and I was like, that's really, I want to try that.
That's nice. I want to try it. Yeah, exactly. So I do that as well. And I think it's a great thing to do when you're more comfortable, because I think that the duodenum can be tricky in the sense that you may think, oh, you know what, I can start out 2 to 3 centimeters from pylorus and I'm going to make my window. And sometimes that won't work because everything's stuck. And so when you have experience, you can say, oh, I need to move more proximal.
Right.
But when you don't, you're going to keep digging in there. And the next thing is GDA is going to say hi. And you don't want to meet GDA that way. And so I think that that's stuff that is good for more seasoned surgeons like you. And I think that people that are starting out, what I like to show is the safest way to do it, that you will clearly see everything you're doing and you're not going to feel nervous that something's going wrong. I do like the technique. I have to use it sometimes when I do a bypass to DS and I'm trying to minimize taking vasculature. The only other problem I find with it is that when you keep all the attachments, it helps you vasculature wise, but it hurts you tension wise. If you have a massive omentum, if you have a very fatty mesentery, a short mesentery, it can be difficult to pull that root limb up. That's when people have trouble pulling the root limb up and you have lots of tension on the anastomosis. You're also sewing right under the right lobe of the liver.
Right.
And so it could be more difficult versus if you're taking the right gastric, freeing everything up, that stomach and duodenum is going to swing all the way down. It's going to come below the transverse colon. So it's technically easier. And I just like technically easier things.
I think also an important point for learners is doing it one way over and over and over. So I did a full dissection for my first year of doing duodenal switch before even thinking about changing it. And part of that is because you're not going to have any muscle memory built up for this operation when you first start doing them. And so I found it, the hardest thing for me was to kind of get a grip on exactly where the GDA was going to be, what angles I wanted to avoid that hepatoduodenal ligament, where I wanted my stapler to come across. That's all foreign. We don't, until this operation, we've never done that. So I think getting that muscle memory down is really important.
Yeah.
Sorry, I was going to ask a question. Thank you so much for the video. I truly enjoyed that duodenal dissection. And I do something similar when I'm doing SADI. We don't do DS, but we're doing more and more SADIs now. And my approach is very similar to yours. The one issue we found is, like you said, with bypass conversion to SADI, because it seems like this dissection can lead to some kind of like poor blood supply with the duodenum being mobilized all the way down, because sometimes to bring that duodenum down, like you showed in that video, you're taking the gastroepiploic and you're also taking some of the right gastric branches, and the left gastric is already, bypassed by because the patient had a previous bypass and you end up doing gastrogastrostomy. So can you comment on that? Like in a case like that, where you're doing a bypass conversion to SADI or bypass conversion to DS, you change your approach, and do you keep that duodenum in situ and dissect around it, like Kunoor was saying, and then staple and then bring that loop or that ileum and do the anastomosis that way?
Yes, and you've set me up perfectly for this slide, so I appreciate that. So two things I would say, and it kind of joins Kunoor's point to yours as well. You know, when you're doing a gastric bypass, the easiest thing is to get into pars and just staple right across the neurovascular bundle of the left the lesser sac, right?
Yeah, which is what
Or
many of us do actually.
exactly, right? And it's so much more straightforward. You know what you see it. It's so easy. Perigastric dissection it requires more finesse. You have to have a better sense of where your vasculature is. You have to have better technique in exposing. And so that's what I feel about the tunnel dissection, which I'm about to show, versus the kind of reverse sleeve where you're just taking the short gastric epiploic, you're just taking everything. So both of them work, but people that do perigastric kind of know they're doing more work for something a little bit nebulous sometimes, like what are you really gaining, but it just feels good to preserve stuff. And that's how I feel about that duodenal dissection. So that's the first point. The second point is that you are 100% correct. If you're converting a bypass to a DS, you should assume that the left gastric is gone. You should assume someone fired the across the neurovascular bundle. You should assume it's gone. You should assume they took it somehow. And if that's the case, if you do the initial dissection I showed, you will have that island of stomach and proximal duo potentially die. And so, and I've seen that. So what you want to do is preserve at least 5 short gastrics along the antrum of the stomach. You want to preserve those, and you actually do want to do a tunnel technique. But even with the tunnel technique, there are a few things to keep in mind. And this is what I'm going to show, where I'm saving the right gastric, doing very minimal superior dissection. And you'll notice I start right at duodenum. Now, one thing I will recommend is to start right at the pylorus. Here, you see the danger in not appreciating that. And that's why I kept this video, is that if you go too distal because you think you're going to pop in, you may be too distal for what you're trying to accomplish. So in this case, I'm leaving the gastroepiploic, I'm leaving the distal short gastrics along the antrum. But what you see here is I think I'm right at duodenum. I'm right at where I should be able to pop through, but I'm actually a little bit too distal. And one of the tell signs is when you're having to do a lot of spreading and a lot of dissecting, because if you're in the right plane, you should have a lot of, there shouldn't be anything back there. Of course, this is assuming the patient is not one of those with a lot of posterior adhesions. So here you could already see I'm honestly just doing too much work that I shouldn't have to do for someone that has a pretty free posterior. And what helps me realize that is that I'll see a little bit of bleeding, and you can see the angulature of the angle of the vessel sealer is very conducive to going too distal, right? And so I'll see a little. I'm like wondering why I'm not getting there, and now I'm seeing a little bit of bleeding, and I go just a little bit more proximal, and I'm going to pop into the window. So here I go proximal, and that's the window I want. Okay, so just moving a little bit more proximal gave me the window I wanted instead of going too distal. This is the window. I don't know if you can see my pointer here, but this is the window you want, and this is not the window you want. And digging through here will get you in trouble. So I think if you're going to use the tunnel technique, start out very close to pylorus, start out right at pylorus to get your window. But still, once I do get my window, I typically don't do superior dissection, because once I pass my stapler, I can see where the anvil is. Here, this is the right gastric, and I pop through right above it. You could get the hook to pop through if you need to, and this is all I need. So again, even with the tunnel technique, I think staying close to pylorus is good, but you also don't need to go crazy with your superior dissection. You can preserve all the vasculature. If you want, like Kunoor said, you could pass a gold finger or what have you. And what you notice is once you divide duo, and this is the argument I would always make, that once you actually divide duo, now all these posterior adhesions and getting a sense of what the anatomy is a lot easier. You could see that these are just adhesions you can take. You can see where pancreas is. You could see the angulature for the hepaticoduodenal. ligament, it becomes a lot easier to understand where you're at. But
Now,
yeah,
after you transect that duodenum, do you keep it the way it is and you bring that loop about, or do you try to swing that duodenum down to get like a nice angle? Because the tension can be an issue too. Even though you've done a good job doing that tunnel,
Mhm.
transected duodenum, and looks pretty well vascularized. I still feel like when you come from behind and bring it down, you end up with a nicer looking anastomosis with less
Yeah,
tension.
I agree.
What do you do in a case like that? Do you keep it the way it is, or do you try to swing it down and take some of those like flimsy attachment and maybe some small branches of the right gastric to swing that duodenum down?
Yeah, I'll try and take what I can. If I'm really concerned, I'll clamp down and just see what happens. Rarely do I do that. Usually you have a good idea of, if you saved all the short gastrics along the antrum and you can see the vessels are fine, the stomach looks good, then you're able to take the right gastric. If there's no tension, I prefer to leave it. But if there's tension, I'm worried that I can't swing it down, then I'll take it. I'm just less aggressive. I think that if for example, I see a patient that the way they did the bypass, they took a lot of greater curvature vessels, then I'm going to absolutely preserve the right gastric. But if I see that gastroepiploic on the right side is still robust, my short gastrics are still robust, and I saved 5, 6 of them, then it's fine. I think when you do bypass to DS, you have to remind yourself that you're not trying to make a perfect sleeve anymore. That ship has sailed. Now, all you're trying to do is a fundectomy, essentially, and a gastric reservoir reduction. You're not going to make a pretty sleeve. So even if you leave more antrum than you would like, more distal stomach than you would like, that's okay. Just get rid of the fundus, make sure you can make your gastrogastric anastomosis, and sacrifice making your perfect sleeve for maintaining your vasculature. Because if it all dies, you're ending up with a scoponero or distal bypass or something of that sort. You're not getting that distal stomach back once it's gone.
Yeah, so that's a good point. That's a very good point. So when you're doing a conversion from a bypass to a switch, and you typically, before I ask that my question, do you typically do it in one stage or 2 stages? Do you reverse the bypass and then come back and do your switch, or do you do it in one stage?
I do it in one stage.
Okay.
Once I do the gastrogastric anastomosis, I feel like bypass to DS, the hard work is in digging out the root limb, digging out your pouch, and making your gastrogastric anastomosis. I feel like once that's done, the rest of the operation typically would take me maybe 30 minutes. So I can't convince myself to not finish the operation at that point, because what's left is relatively straightforward. Now, of course, if there are a bunch of pelvic adhesions and I feel like it's taken so long to get the pouch out, then I may do it in 2 stages. But that's really an exception to the rule. Most of the time, I'm doing it in 1 stage.
Okay, but you're saying when you do that mobilization and the gastrogastrostomy, you try to preserve the gastroepiploic arcade, and try not to take it down and do a good sleeve gastrectomy like you would usually do.
Right.
Open to preserve that blood supply to the antrum and to the proximal portion of the duodenum when you're doing your duodenal ileostomy.
Right. And the other thing that you could do that's really, really helpful is, instead of, again, it goes to the principle of don't try and make it a pretty sleeve. Don't try and make it the sleeve you're used to. You need to get rid of that in your mind. Just concentrate on reducing the volume of the stomach and doing a safe GG. The most dangerous part of the operation is your gastrogastric anastomosis. So you want to do everything you can to not have a stricture, which will be miserable for the patient, and also to not have it leak, which is miserable for you and the patient. And so sometimes it's better to actually land that gastric pouch proximally to the lesser curve. Instead of trying to land it to your staple line, instead of trying to make this a pretty sleeve, just it'll look like Frankenstein, but functionally it's better, and it's better for you and the patient to land that gastric pouch to the lesser curve. Because the vasculature there is much better, and you're not putting staple line to staple line, and it helps with your tension as well. So I think those are things to keep in mind, in particular when you're doing a bypass to a DS. I think it's probably the most challenging bariatric procedure, bypass to DS. It's very challenging. I think everything else is less challenging than that. So if it's a whole animal of its own, just knowing all the tips and tricks to make sure that you do it safely.
Can we take a step back for a minute? So whether we're doing it lap or robotic, for people who have not done a bunch of these, can you just kind of walk us through what would happen if you were doing this dissection, for instance, and you got into a bunch of bleeding? Like, what's your step-by-step approach to dealing with this?
Absolutely. So, prevention is better than cure is the first thing. And so when I'm doing a duodenal dissection, and I'll touch on that, my goal here is to get into, and this is not this is a native virgin abdomen. This is not a revision. This is just a straight up duodenal switch. So the two principles to remember, I think, on duodenal dissection, once you get into the lesser sac, you want to pull the stomach to the patient's left side. What that does is it medializes the duodenum, right? And then you do a reverse sleeve where you just march this down. If you feel like it's kind of hiding under the right lobe, or you can't really see it well, just pull a little bit more to the patient's left, and it should pull the duodenum out so you can see it. I concentrate on the inferior dissection, so I'm pulling to the patient's left, and the vessel is coming this way. Then
will you pause it for 1 second?
Sure, absolutely.
One quick point to the fellows, and you did this subtly, but for people who are new to this, when you come around that bend of the stomach, and around also to the duodenum, the anterior doesn't necessarily match the posterior. So he's looking both anterior and posterior, because you could easily burn posterior when you think you've come across it because you only looked at the anterior leaflet. So obviously your eye is extremely seasoned and you know where both of your tines are landing, but just as you're watching this to the fellows, just make sure that you know anterior and posterior where you are.
Yes, very good point. And if you're having trouble delineating that, then take your anterior leaflet. If at any time you can't tell where posterior is, take your anterior leaflet before you take the posterior. Once I'm done with kind of that, taking the inferior dissection, I'm going to put the duodenum or the stomach at 12 o'clock. And this is to just concentrate on the posterior aspect. In this case, there wasn't much there. So literally this is the end of my dissection. I'm not going to do anything else to it. And that's the part that sometimes you would say, what? That can't be. It can't be that easy. But this is absolutely fine. I'm going to retract the liver up because I do want this to be flat. And then this is the view I want, right? This view is very important because patoduodenal is down here, right? If you grab this fat and lifted it up, you're going to see caudate lobe. And this is the angle you want. In the past, I would take these little perforations, perforating vessels, but you don't even need to do that because the stapler is going to take care of that. Julia, I'm going to get back to your question. I haven't forgotten. And the anvil is clearly seen. What's interesting is this tissue here superiorly is what people spend a lot of time dissecting, but you're going to dissect it. You're going to take it with the stapler anyway. And the other thing I want to point out is you see how the stapler is actually hubbed all the way. Okay, the stapler is hubbed all the way because, I kid you not, this is barely going to get across duodenum. Barely. It's going to get across it with a little, like a millimeter or two past it. So again, it's relatively difficult to do harm.
You always use a white load there.
I didn't start out using a white load. I used to use a blue. It bleeds more, especially if you don't pre-dissect out the superior aspect. A white load on the robot stapler, I think, is better for hemostasis. And if the duodenum is thick, it's going to let you know it's too thick to fire. And then every once in a while, it does fire halfway and then tell me it's too thick. And that really makes me mad. But it's not that big a deal because you just load up a blue load and you fire across. If you're worried about the staple lines crossing, what you should remember is that focus on making sure the duodenal stump side is good. You could always fix the proximal. You could do all kinds of things to fix the proximal. You don't want to be messing with the stump. So if you're going to make anybody happy, make the duodenal stump the happy camper. So here's the course of the pole triad. If you finish doing this and you get into bleeding here, one of the things I recommend, the first thing I would recommend is not to panic and just pack it first. Don't start clipping like crazy. Don't start suturing like crazy. Don't freak out. Get a ray tag, get something, and just pack it. Just pack it, get control, let anesthesia catch up, change your underwear, do whatever you got to do. And then you could come back and address it. And when you come back to it, I would lean more towards using product like flow seal to seal, something like that, than stitching and burning. Because there's a lot of real estate in this area that's very important, and you don't want to be doing anything blindly. Okay. If you see that it's a significant vessel or something you've injured, you should be able to keep pressure on it and get help, right? If you have hepatobiliary, etc., and get help. If you don't, then you're going to sit there, okay, until you have adequate hemostasis to now start teasing out what's going on. But again, prevention is better than cure in this instance. Prevention is way better than cure. And that's part of the reason I use this technique is I don't want to get into portal vein. I don't want to get in hepaticoduodenal, hepatic artery. I don't want to get into any of that stuff. And so it's very important to use really good technique. Again, the bleeding you're going to run into there, something like the GDA, if you hold pressure on it, it will stop. You don't want to blindly stitch there. The pancreas is right there. You don't want to stitch off your pancreatic duct. You don't want to get into portal. You don't want to do any of those things. So again, don't panic. Most of the time, if you pack this stuff off, just like trauma principles, the bleeding slows down enough for you to now piece together what happened and to address it. If you're going to sew something, make very well sure that you know what it is and you see it well.
Folahan, two quick questions just to highlight some important aspects of this procedure for the fellows. The first one is something that you, I think, mentioned at the beginning is the extent of the dissection. And I love how you, started the dissection at the interim and went all the way down. And this seems to be kind of like the best approach, at least for SADIs, when you do a sleep conversion to SADI, because sometimes that, those vessels were already taken down. What's the extent of your dissection? First question, do you stop when you see the GDA in the back, or do you stop when you see those like small perforating branches supplying the posterior wall of the duodenum? That's the first question. And what's your take on ICG in robotic cases? I like ICG. I don't use it in primary cases that often, but in SADIs, I tend to do it pretty routinely just to make myself feel better about that duodenal stump and the duodenum, especially when every time you transect that duodenum using that approach, you end up with a blue duodenum, and then you wait for like a few minutes. By the time you give the patient ICG and you fire your Firefly, it starts looking better. By the end of your anastomosis, it's pretty pink and you're happy and you have a smile on your face. But you minute you transect the duodenum, there's those like initial 10-15 minutes where the duodenum is not looking that good, and you asking yourself, why am I doing this?
Right. I'll answer your last question and then go to the first one. I find ICG very interesting, especially when it's used to kind of identify if something is still vascularized. Most of the time, most surgeons have decided what they're going to do. And then they use the ICG to feel better. So if you want to take something, if it doesn't light up, you're like, I knew it, out it comes. If you don't want to take something, it shows you one strand of green. You're like, there's blood flow. We're okay, right? And so I feel like a lot of times we use ICG to feel better, but not necessarily to make clinical decisions. We already kind of know where we want to go. I love it. I think it's fantastic. I just don't use it often because I know that on the rare occasion I use it, I want it to really make my clinical decision making better. What do I mean? Sometimes I'll be distalizing a bypass and it will be a retrocolic, retrogastric. And I don't know what the root limb is versus ligament. Which one of you guys is ligament? Which one of you is root? Everything above is buried on the liver. It's miserable. I'll have anesthesia put ICG in the gastric pouch, and then I'll see which bowel lights up, because whichever one lights up has to be the root limb. And I think like in instances like that, or when you have a complicated gallbladder and things like that, it's very important. I think when you're doing a duodenal switch, if you're really concerned, hey, where's common bile duct? Where's everybody important? Then I think ICG is really, really good. There are people that use it for their leak test. I think that's great. One of the criticisms is that it's too sensitive.
Hey, Paul, can you stop for, sorry, 1 second,
Sorry.
for the fellows to delineate the difference between oral use and intravenous use. Some fellows might not have yet been exposed to the two different
Thank you.
uses. So leak versus vascularity.
Thank you. Very, very, very good point. Because even when you tell anesthesia, I'm going to use ICG, sometimes they don't know what you mean. And so there's ICG for leak test that's giving enterically, via your VCG, your nasogastric tube, what have you. And what you're trying to figure out is if gastric juices or enteric juices are leaking out, is your anastomosis okay? And then there's intravenous ICG, which is used to check for vasculature, which is used to make sure that tissue is still perfused. And you can also give it intravascularly, and then it ends up in your biliary tree. And that also helps you delineate what's going on with your biliary tree, i.e. knowing where common bile duct is, knowing where cystic is, and things like that. So those are the different ways you could use ICG. I don't remember all the concentrations. Maybe you guys can weigh in on that.
So actually, I am going to interrupt you again. Sorry.
Please.
About this. We have a bariatric happy hour special on the use of ICG in bariatric surgery, and it's really good. So if you guys go on ASMBS's website or just Google it, it should pop up. It's on YouTube. So it will go through like how to use it. And I think there's also information about the dosage.
I think you and Kunoor just set that up as a plug. Well done. So the second question Maher asked me was or commented on was, how do you know how far to dissect? One of the ways that I tell is when I'm taking down that inferior dissection, I run into where the duodenum fuses with the pancreas. That's a perfect tell. I don't care if the GDA is there, if I'm seeing the posterior perforating vessels or what not. Once this kind of fuses, I'm good to go. I know that's kind of where pancreas is fusing. Now, one of the things people will notice and comment on is to say, well, sometimes that's not a whole lot of duodenum. That's actually not true. Here's why. When you go to staple across this, it's not the posterior length that really matters. It's the anterior. And the anterior is not attached to anything. It's completely free. So when you pass the stapler, when I pass the stapler through, I can get additional duodenal length by just sliding that anterior wall of the duodenum past the stapler to get more anterior. Now, one of the things you notice is that anytime someone goes to go do, so you notice, I don't know if I do it in this case, but you could literally grab this anterior duodenum and pull on it and slide more tissue in. You could rotate the stapler counterclockwise and get even more anterior tissue. And what you notice is when people go to sew the duodenal ileal anastomosis, they're never using the posterior row. They're using anterior row only. The sutures go through the staple line, and we ignore the posterior row. So you don't need a whole ton of it. The anterior row or the anterior wall of the duodenum is adequate. So something like that also helps me not have to do a lot of posterior dissection in the interest of trying to get 2-3 millimeters extra of duodenum, because to me, it's just not worth the kind of trouble you can get into. There's no particular benefit, in my opinion, in killing yourself trying to do that. Now, if you're very experienced and you're very comfortable, you could do that. But I think once you start seeing fusing, you can stop, and that's usually enough. Now, I have, I've posted these videos on some of the robotic collaboration on Facebook and things like that. And that was one of the criticisms. Hey, are you getting enough duodenum? And so I've actually gone and measured it out, and I'm routinely getting 3, maybe 4 centimeters of duodenum because, and that's the duodenum not on stretch, measuring it with the open Cartier grasper.
All right, so I have 2 questions for you. The first one comes from the audience, Dr. Zarzuela. is asking, in your experience, what are the most common surgical complications with going from a Roux-en-Y gastric bypass to a DS?
The biggest complication is your gastric anastomosis leaking. That's probably the biggest complication. I won't say it's the most common, but it's the most concerning. Here are a few reasons why. If you use a circular stapler, you have two options in terms of the staple length height. That's it. So if you're using a circular stapler to do it, you're either going to think, I think it's the 2.5 or the 3.5 or the 3 of the 3.5. And so if the tissue is too thick, your staples won't go through the tissue well. And I've had this happen to me because I've done it every single way, where I used a circular stapler. It looked beautiful. I did a leak test, negative. I did an upper GI the next day, negative. It looked fantastic. Everything was great. Patient leaked day 10. And basically the staples didn't go across. That's part of the reason, the main reason I actually switched to the robotic platform, because there's no way to tell how thick that tissue is on that revision. You just can't tell. You could guess, you can look at it, you could try to use previous experience, but it's very hard to tell. When you use a linear stapler, same thing still applies. So I like using the robotic platform for this because it lets me know how thick the tissue is, make sure the staples fire across, and then it's easier to sew up there in the event that the pouch is so small you have to do a hand sewn. So if you're going to do
I'm not
Roux-en-Y
going to
to
name
DS,
any names, but there is a linear stapler that does have intelligent loads that when it
Yes.
is able to tell you as it's firing, how difficult it is for that stapler. So the technology hopefully is coming.
Yes. And so if you're going to do this with a linear stapler, I think it's important when you're doing revisions and stapling to be able to have something that's going to give you feedback on how thick the tissue is. Because I kid you not, you could do every single leak test you want, and 2 weeks later your patient still has a complication. So if you're going to do Roux-en-Y to DS, my recommendation is to get very comfortable, very facile with the gastric anastomosis. Land your pouch onto the lesser curvature for more vasculature, better vasculature, and really learn how to make a good GG. I think the second thing is more bleeding. And part of this is because you're just doing more. And there are things that don't look like they're going to bleed that would bleed on you later on. So you have a higher rate of post-op bleed. It's not as bad because usually transfusion or even just observation is all you need. You rarely have to go back in, so it's not as worrisome. But it's that GG. The last thing I'll say is that makes the GG an issue is that it's an island of tissue, the distal stomach and duodenum, that could be very devascularized as well. And so it has tension, it has different thickness of tissue, and it has poor vascularization, which is a perfect setup for a leak. Now, if that wasn't bad enough, because of the issues with vasculature and because it's the stomach that you're dealing with, once you get past the leak and you think you're safe, you get to level 2, where the gastric anastomosis wants to stricture. And so when you make that GG, you want to make it as wide as you possibly can. Don't think bypass, I got to make it 3 centimeters. Make that thing as wide as you possibly can, because when the stomach strictures down due to lack of good vasculature, it is horrible to dilate it out. It just won't stay dilated. It will stricture back down. And now you don't have really good options because your patient has terrible reflux. They have gastric outlet obstruction. And you don't have great options to treat that. So it's that gastric anastomosis that you really have to pay attention to. Good question.
All right, my second question is that I noticed in the video you just showed us that you have a gallbladder in a specimen retrieval bag. How do you normally handle the gallbladder at the time of a DS?
Before insurance companies became doctors, I would routinely take the gallbladder out with every duodenal switch. It is horrible to go back in an acute chole where the gallbladder is stuck to your duodenal stump staple line. It's just pure misery. And the risk of gallbladder disease is about 30-ish%. And so I prefer to take it out. Insurance doesn't always cover that, so sometimes I can't. And I also give patients the option, to be honest. If they say I don't want you to take it out, I don't. And then I'll see them back a year later and we'll take it out then. But in general, I would like to take the gallbladder out. Now, I know that there are people that routinely leave it in and don't feel it needs to come out. So I don't think that's settled science by any means, but my preference is to remove it. I've personally had to go back in and take someone's gallbladder out, and it took 3 hours to get it out safely. And it would have taken me 10, 15 minutes if I had taken it out at the same time.
We have one more in the chat. What is your pre-op workup for a conversion between a Roux-en-Y to a DS? Is there any imaging that you do to evaluate the vasculature, especially the right, left gastric patency?
So it looks like I haven't convinced anyone to stay away from this operation. So, okay, game on. So I do an upper endoscopy every single time. I personally do the upper endoscopy. I don't believe anybody else, and I want to know what's going on because I don't want to be surprised when I get in there. What am I looking for? You want to know how big your pouch is. A big pouch is a godsend. You want to thank the surgeon that did the bypass. They may be hating it, but you're going to love it. You want a nice big pouch you could sew to. If it's a micro pouch, you may be forced to use a circular stapler. You may be forced to hand sew because there won't be enough room to use a linear stapler. And that's stuff you want to know ahead of time when you're going in. I don't routinely study for the vessels. I don't think it's a bad idea, but I think that I'm experienced enough at it to see what's going on intraoperatively. And what I mean by that is I'm always going to preserve the distal vasculature to the stomach. I'm going to try my best to preserve the right gastric. I think that even if I know the left gastric is there, I'm still going to do those things anyway. And so I don't feel like it really moves the needle on my decision making because I really want to preserve the vasculature to that distal stomach as much as possible. So I don't routinely do imaging to evaluate vasculature, but I am going to do an upper endoscopy. The second thing that I will do is get an op report. Sometimes I'll see patients that have had a bypass and then they've had a bypass revision. And what that bypass revision usually is a completion gastrectomy. Someone's gone in and resected their distal stomach. And if that's the case, you can't do a bypass to DS. I've been surprised by that, getting in and you get the roux limb out, you get the pouch out, you're looking for excluded stomach, and all that's staring at you is pancreas because that distal stomach is gone. So if there's any question, if I can get the op report, if patient's not really sure, then I will get a CT scan, but I'm just looking to make sure they have that distal stomach still there.
Folahan, what do you think about the bypass to DS versus bypass to SADI? Do you think there's any benefit in bypass to DS versus bypass to SADI? I know it's not settled. What's your take on it?
My biggest concern with SADI is just bile reflux. And there's not a lot of it, but when it does happen, it's miserable for all involved. And I know, I have a slide on here that talks about Cottom's experience. The long-term benefit of the SADI is just less complications nutritionally and things like that. Well, when you look at weight loss, it's not as good. And so I feel bad for a patient that's had a bypass and I'm doing this big operation to a duodenal switch to put them at a position where they may end up needing yet another weight loss operation because the criticism is pretty harsh. The more patients have these operations. So for me personally, I still lean towards, hey, I'll give you a SADI if you had a previous, if you're coming in for the first time having an operation. I'll even do it for a sleeve that's relatively low BMI, 40 or something like that. But once you're at the point where you've had a sleeve and your BMI is still 60, your BMI is still 50, then you're getting a traditional DS from me because I just want to give you your best shot at losing the weight. One thing I do like, earlier on you were talking about staging. I think that if you get to a point where you've done the gastric and now you're like, what, I just want to be done and get out of here because, for whatever reason, then bringing up a loop and being done with it, I think is very reasonable. But like you said, I'm looking forward to when the science gets a little more settled on it, because I don't know exactly when to do the SADI versus the DS. But my general principle is I know DS is as aggressive as you can get. So for someone that I feel like, hey, it should be a one and done, I'm going to lean traditional DS.
Very good.
So this video is to not make the previous videos seem like every DS is a chip shot that's easy. I still don't like watching this video, and it still makes me feel a little bit like why was I here and why was I doing this? And because this is a patient that's had a previous cholecystectomy, and I'm converting their bypass to a DS. You know, you may look at their history and see lap chole and say, oh, that's fine, we'll go ahead. But I want to show this to say that look at that patient's history, because if they've had a previous gallbladder, you could run into significant adhesions that will make this duodenal dissection a lot more difficult. You know, I always say that when I watch this video that you see me doing a lot of lysis adhesions, and that's because I'm trying to avoid doing the duodenal dissection itself. And so I make myself busy doing something else, so everyone in the room doesn't realize how tense I am about what I have to do. So it can be a mess. I think that this is a kind of thing where you don't want to jump right in on your first DS doing something like this. You want to really get comfortable knowing what the anatomy looks like and what your technique looks like. So again, I'm stalling. Hey, give me a Raytech. I can't move forward without one. As I'm trying to figure out how I'm going to attack this. Here you can see common bile duct staring at us here. You can see duodenum is kind of stuck up there. And here you can see the clips from the previous cholecystectomy. So you can see how duo was literally stuck right up on that clip. So again, the take home here is that please do pay attention to the patient's surgical history. If they've had a previous chole, you can run into trouble here and have to be very careful knowing where everything is. General principles is that your inferior dissection is by and large your safest dissection. If you could get a posterior window after dissecting your inferior dissection, you're in really good shape, and you'll probably be able to come across the duodenum. Have you guys encountered adhesions? Kunoor, have you encountered adhesions like this?
The last three I've done all had
Yeah.
lap choles, and my poor fellow, this was in July, that the bad ones, and really seasoned fellows, and even they were like pretty dejected because
Yeah.
you're spending 2 hours honestly on this dissection, and some of
Yeah.
them, and this is one reason that I'll actually stage a DS, is because if I'm at a BMI of 60 something, we can't even see the duodenum, and I start doing this dissection, I'm like, we're going to be here. The sleeve already took, let's say, an hour and a half just because of BMI issues, and I know I'm going to be there for another 3-4 hours. I'm starting to worry about issues with rhabdo and stuff like that. I'll say, let's be done with the sleeve. Let's come back another day when their BMI is down in the 50s or 40s, and let's spend 3 hours doing this dissection and the actual DS.
Yeah, 100% agree. And you see, it gets easier when I get closer to the pylorus and just start the dissection from the pylorus rather than trying to dig it out from right behind the duodenum. You can see we're sitting right on CBD here. But I'm starting to create a posterior window. And once you get that posterior window created, it becomes a lot easier. I mean, this is sped up, so you can't, you know, obviously in real time it was slower, so I could see that posterior window. And once I got that posterior window set up, which is this here, now I can have a lot more confidence in passing the stapler behind that. And so for me, the whole game here is getting that inferior dissection done, making sure posterior is free, and then I'm going to pass the stapler and just make sure that the stapler is hugging right on the duodenum. So again, you know, a virgin abdomen, a fresh belly, duodenal dissection can be very straightforward. Even if they have pancreatic adhesions from pancreatitis or what have you, it's easy enough to push that stuff down. But if they've had a previous gastric bypass, in particular a previous cholecystectomy, it could be pretty miserable. So here I am passing the stapler behind. I could see where the anvil is. None of this is blind. I could tell where the tip is. I could tell where CBD is, hepatico duodenal is, and things like that. And so once I staple, now you can see Kamabada is over there. You could really now under direct vision take some of this superior dissection down to free up the duodenum. So here's a room-wide to DS, and you can see there I took the right gastric because I just felt like I needed to be able to swing this down. So again, that dissection is not always easy. You don't want to start with one of these. What's my advice if you get in there and you run into this? What Kunoor said, you're going to do a sleeve gastrectomy and get out. If you're doing a revision, it may be reasonable to abort it if you're not comfortable. It's much better to abort a case and feel bad you aborted than to continue, get in trouble, and feel bad you got into trouble. So it's better to just quit while you're ahead, because you can make things worse without a doubt. I'm going to keep going until you interrupt me.
Well, I actually had sent you a private message, which clearly you didn't see, but that's okay. We're actually a little over time. And
Okay.
I love that you have so many videos. I don't know if you maybe wanted to show one more, and then we could end a little bit after that.
Sure. No problem at all. I warned you, and I cut out a lot of video too. So I warned you we could go on for a couple hours. So a few things I just wanted to show. Counting bowel laparoscopically, for me, I use laparoscopically, I use the Babcock's graspers. I need to get back on this. But robotically, I use the umbilical tape. It takes a little bit of getting used to, but once you're used to it, I think it's superior because the tape curves along the bowel. You don't have to have everything to be straight. This really helps if you have a whole bunch of adhesions and have to deal with that. So I think I'll leave it there because we spent a lot of time on the duodenal dissection and kind of the upper aspect of this. But for the small bowel side, a strong recommendation if you're doing this robotically is get used to counting the small bowel with umbilical tape. And the reason why this is important is bypass, you can guess on bowel limbs and it's not a big deal. No, it doesn't really matter. 100, 110, doesn't matter. With a DS, you need to count right. You can't guess, you can't eyeball it. If you count too short, your patient will be back. I can almost guarantee you that they'll be malnourished and you have to go back in and do something. So it's really important to have a really good counting technique, whether it's using the instruments or using umbilical tape. I find umbilical tape just is more versatile for you. All right, I'll end there.
How long do you make your umbilical tape?
I find that 25 centimeters is a sweet spot. Some people use 100. I find that the umbilical tape, as you're counting, will get wrapped around your small bowel. And so it could be very difficult to manage if it's too long. Most of the time when we're doing these counts, we're doing increments of 25, right? You're going to do 100, 125, 75. So we're always doing kind of increments of 25. And that's not by accident. When Dr. Hess described this, he would measure out the entire bowel. He'd do all his percentages. And then when he was done with all that work, he'd round up to the next 25. Okay. So in general, 25 is a good marker that allows you flexibility, and it's easy to manage the umbilical tape a lot better.
Okay, fair enough. All right. I would love to continue watching videos from you. Maybe you can just put some online and we'll follow your website and try and get to them.
Okay.
Have to have a part 2.
Yeah, I know. I can't wait to come back.
Great. Well, thank you so much for taking the time to chat with us. I'm sure the fellows, really appreciate watching an expert at DS show them how to make it easy. You do make it look really easy, honestly.
I'm telling you.
Relatively, I should say. Relatively. And I would like to thank all of my co-panelists for joining us tonight as well. We'll have another session on the 4th Thursday, and it will be a journal club. And again, remember, guys, that we'll have the fellows project presentation on the 1st Friday of the month. All right, we'll see you guys again soon.
Nice job, everyone.
Thank you. Good night.
Have a good night.
Good night. Thank you.